Hi, everyone. I'm Mark Plaster, and this is EP Talk, the place where emergency physicians, aka ER docs, come and talk about everything that's important to us and the new and latest developments. And I pull on experts in various fields. And today I have Dr. Jeff Johnson, and we're going to be talking about blood clots. And you know, I'm an old dog, and the old dogs are used to just when you got a blood clot, you basically all you could do years ago was to give them anti thrombolytics, or you could give them heparin. But today, it's commonplace to mechanically take care of blood clots, but that takes a whole team, and that's what I brought Dr. Johnson in for. Jeff, tell us a little bit about yourself. Give me a little bit of your bio, your thumbnail, and we'll go from there.
Sure. Yeah. So I practice in Tulsa, Oklahoma, Hillcrest Medical Center. I'm the medical director of the ED there. We see 50,000 visits or so a year. We have a training program associated with the University of Oklahoma. I'm somewhat affiliated with that university, but really I'm a clinical private practice guy. We have a physician-owned group, which I'm a partner in. So yeah, I'm the medical director there of this facility, Hillcrest Medical Center, and I've been doing that for the last few years. And yeah, we've got some great things going on there.
So let's back up a little bit and let's talk about the various kinds of clinical situations that a emergency physician would find themselves in, and the application that clot mechanical removal of clots would involve. And let's talk about the requirement that would come as the result of the new approach. It used to be, like I said, it used to be that you just ordered heparin and you were done with it. But now, yeah, it didn't work. That's the point of it, is it didn't work.
Yes.
It didn't work effectively. And that's the major advancement has been to mechanically remove emboli. And that's where this new equipment made by Penumbra is involved. But where that impacts the emergency department is, number one, do you have that kind of capability? Do you have that kind of skill set in your team members? And do you have the team built and the capability of putting together a response in a timely manner? So
yeah,
tell us how you guys did. Start from the beginning and how you brought built that team.
Yeah, and I would love to say that I really could take credit for the creation of the team. I can't. I'm just really kind of a cog in the wheel. But as an ED physician, you know this. The best way to get something done is have it be somebody else's idea. So that's great for us. Like, yes, this is going to help me, and it's your idea. Let's do it. So really, it was kind of our vascular guys and one of our interventional cardiologists. They got turned on to the technology, which is really the game changer. The fact that you can go in and you can remove clots from the pulmonary artery, it really changed the game. So they were excited about it, number one, and that really changed it from what you said. It used to be you gave them something to thin their blood down, and then you just hope for the best. And now people are like, hey, when you see one of these, call me, because I'm excited about it too. And it used to be you couldn't get anyone, no matter who you called. Like, this seems like this is something you should be involved in. They're like, not my thing. Just put them on some blood thinners, So yeah. That's really how it started with us, is that the vascular guys really kind of brought it to it. And then we were just involved from the diagnosis and getting them on board.
But when I started looking into the actual machines themselves, this one we're talking about made by Penumbra, one of the sponsors of our broadcast. But Penumbra, when I talked to the guys who were actually doing the procedure itself, it was unique in the sense that you'd think you just stick a catheter in there and you suck the blood clot out, but it's a lot more complicated than that. And it has to be the mechanics of getting the clot out are much more difficult. And Penumbra has a whole range of products that actually get clots out of different locations: arterial, venous, cerebral, pulmonary, and a lot of different applications. So that's why a interventional cardiologist would be the guy who would be the champion for this technology. But as we both know, the emergency department and interventional cardiology are now married at the hip in a lot of these clinical situations now. And you may have a great interventional cardiologist, a great cath team, but if your ED is not functioning at 100%, you're not going to be saving the patients that you could. So how did you guys bring your ED up to speed?
Yeah, they were really they really helped us in that way. And they just said, call us for every single PE, call us for every single one. And then we'll decide, and then we'll start working through who's a candidate for the thrombectomy and who's not. And so that was really nice, just to kind of have, get the decision makers, for them, they wanted to work hard. So we're grateful for that. They just call us 24/7. If you have a PE, we'll talk about whether or not we're going to do it. And then out of that, over time, because it was such novel technology when it first started a few years ago to now, we have a good idea who's going to go and who's not going to go. Still, we do consult them on every PE, but we also know at this point, they're not necessarily going to take them to the lab tonight with, without, seeing some evidence of heart strain or something like that.
Yeah, exactly. I've worked in some very, very remote situations where basically you only got to do that if it was a saddle embolus and, where it was life-threatening.
Right.
Certainly not the circumstances that you have today. Give me an example, a feel for the kind of patient that would undergo thrombectomy.
Yeah, so I think these are going to be people with a fairly large clot burden, and you're going to get your CT scan, and now the radiologist, if they're starting to talk about the septum, the ratio of the RV to the LV. So they're going to start telling you on your CT reads at this point whether or not they think this person has evidence of heart strain, which, really 5-6 years ago, the radiologists weren't commenting on that unless it was massive, right? That almost was a novelty to them. Like, look at this guy's heart. I'm going to talk about it in my dictation, and now they're calling it on every single one.
Calculating it, in fact, aren't they?
What's that?
They're calculating septal deviation.
Exactly. Yeah. Ratio RV to LV. So they're, so we see those. We're talking to the team, and I remember initially one of the interventional cardiologists, he said, just remember PE equals NPO. If you start there, we're going to be on good. So start thinking every single one of these guys potentially could go to the lab, make them NPO, get them ready for the lab, and then get them on the phone. And then, we're still doing heparin on these folks as we get them ready. And even if, sometimes they're like, well, we're not going to take them tonight, but whatever, heparinize them, and we might end up look a little further, get an echo, that sort of thing, and then we'll decide what we're going to do. So it's really there's been a lot of development on these people.
What kind of acceptance did you have? What were the political implications of developing this team approach that you have there in Oklahoma?
Oh, it was great. I think the team, the folks that started it up, they hit the ground running. Everyone was on board, and I think that's one thing that you see. As soon as the word got out that we were doing this, then the transfer calls, started coming in from hospitals across town. Rural, of course, like you're saying, you're working remotely. Now the change is different, right? You're saying, who's doing thrombectomies that I can get this patient to, so we have, then all of a sudden you're just, it's crazy. It takes off. So yeah.
Yeah, I spent the latter part of my career working at a full service freestanding emergency department, which if you've spent, I'm sure you have always been in an emergency department that was attached to a hospital. But I tell you, it's sort of the Wild West when you're out there. It's a full service ED. I mean, you've got CT, you've got everything that you need. But you've got to have the folks like you on the other line to be able to pick up the phone and say, and this guy's got to go to the cath lab.
Yeah, and that's one thing that I would say we have a very strong partnership with the cardiovascular team and the ED is that we really focus on saying yes to just and to be an easy access point for free. We don't have freestandings really in our city, but rural, there's a lot of rural places, and
Yeah.
if you call us and you need us, hey, yeah, sounds great, get them here. We've got people, we've got teams. It's going to be easy on us to figure out, even if this person is an interventional candidate, we'll sort it out when they get here, and really just kind of take that burden off those people out there who are doing hard work. I work in rural settings also. Our group has about 14 EDs in the region, so I'm out there in those on the other end also.
Do you fly a lot of patients back to the tertiary care centers from the rural EDs?
I would say we fly a fair number. It's a distance thing, but also just with EMS shortage, manpower shortage, just like every other healthcare, EMS is sometimes you just can't get a truck. You think, I don't need to necessarily fly this guy, but it might be 2 or 3 hours to get a truck, but I can get a helicopter in 20 minutes. So I think a lot of that is just, it's a manpower issue. So I do think we've flown quite a few people, especially if you have, it's easy to justify to think, well, this person's going to be in the ICU. Okay, yeah, let's fly him, So I think you can talk yourself into it for sure.
I'm just actually, the reason why I asked the question is a tertiary care center that has an active EMS, both ground and air, effectively increases your impact, your ratio of patient, your catchment area, shall I say. It increases your catchment area significantly because you're doing a procedure that they can't get anywhere else.
Right.
And it's clearly indicated now. It's not optional. It has clear indications, and so it really is tying our system together more and more tightly, and increasing the importance, of course, of tertiary care centers and increasing the capability of the rural center. You go into a rural center with a problem, you don't know, patient's short of breath, and suddenly you find out what they've got, and you can pick up the phone, call you, get an acceptance, get a truck or get a helo, and next thing you know, they're out of there and they're in the cath lab, which is a miracle of American medicine, to be perfectly honest.
Yes, I agree. I agree because prior to kind of having a reason to transfer this person, this person could have been kept out at the rural location, or you're transferring them, and maybe the transfer accepting physician's like, why are you transferring this person? It's just a blood clot. All we're going to do is do the same thing you do, give them some thinners, right? So I do think this technology has created the reason to transfer someone, which is helpful, I think, for the rural doc. It makes your decision or my decision much easier.
Yeah. And I think that what you're offering the patient is hope for a better outcome. And that's the key. That is the key. I mean, we're going to try to reduce I've always been honest with patients to say heparin doesn't actually break anything up. Okay.
Right.
All it really does is it prevents it from building a whole lot more. And so what you have right now, essentially, you're stuck with.
Yeah.
And if it's straining your heart, well, it's going to strain your heart.
Yeah.
And that I mean, I'm old enough to remember having those conversations,
Sure.
And
absolutely. I always use the term that like scales. Heparin tips the scales towards clot breakdown versus clot formation, similar type of strategy. But yeah, absolutely.
And now with this technology incorporated into this system, the cath, essentially the cath lab, the ED, the EMS, we actually have a significantly improved outcome that we can offer to those patients. I think that's pretty cool.
I agree. I've long said that, I think thrombectomy and stroke was one of the biggest game changers in my practice time. And then now this similar, it's the same process, thrombectomy. Both of those, for those two disease processes, have really changed the game, I think, of patient outcomes.
Yeah, for sure. That is absolutely for sure. I'm still curious. You sound like you had no problem building that into no political barriers in your facility. I can imagine that some hospitals, especially if it's generated from the emergency department, might find themselves with political barriers. No?
Yeah. Luckily, our cardiovascular program at our hospital is really like foundational for what we do. We, you know, our they do everything, whether it's structural heart disease. I think last year we did the first valve of some sort in the world at our hospital, and there, so we're doing some, you know, we're doing a lot of crazy stuff, and so um, they have a ton of support, they have infrastructure, they have a political power base within the hospital. So if they're like, if two or three of these guys, and they're great guys and they want to work hard, if they say, hey, I want to do this, then yeah, they did it. And you know, at first it was it was the interventionalist or the vascular surgeon and their APP might, you know, it was, they were the team, whoever was on. Now they have dedicated, you know, they've got someone who's doing registry, you know, they're recording all of their, documenting all of their cases, and then uploading them to a national registry. So they've got coordinators now. They've got a dedicated team of you know, APPs, and that's their service under the interventionalists. And then went from 3 guys doing it to maybe 7 or 8 now, because
Wow.
it's I mean, they're busy. That's it's crazy.
Well, that's what provides a system that really can be spread out to a lot of people, can offer to a lot of people. And the reason why I even brought up the whole politics issue is I've seen programs that only had 1, 2, 3 champions, what I call champions,
Right.
guys who are willing to really do the hard work. And an interventional cardiologist who feels like he might be on call every 3rd night.
Right.
That's going back to residency training. And if it's grow or die, you know, grow or wear your people out.
Right.
And what you guys have done has shown how you can scale it up and make it available to more and more people and actually make it easier to do.
Yes, absolutely. Yeah. In fact, if you think about, you try to admit these people, so we have a CV ICU, you know, and a med surg ICU, and you try to say, I think this guy is pretty sick with a big PE, you know, I feel like they could go to the CV ICU. You get the interventionalist on, they're like, nah, send them to the med surge. You're like, isn't this your world? You know, and no, not really. You're just going to put them on heparin, right? And whatever. And so
Yeah.
now they're on the team too, right? So you've got your admitting docs are lining up. They, in fact, we sometimes if they're meet certain criteria, they're putting them on ECMO prior to thrombectomy.
Yeah.
So they're ECMO prior, doing the thrombectomy for support with the ECMO, and then decannulating them after. So everyone is really on board as they've seen, you know, getting excited about the outcomes, really.
Yeah, you mentioned ECMO. Here at EP Talk, we've talked to the guys out on the West Coast who are really championing ECMO and the expansion of ECMO. And the reason why, again, I go back to politics is because you've got to have you've got to have an increasing interest in the group willing to do these complex interventional procedures in order for it to work. You get a
Right.
handful of guys, 1, 2, 3 guys, and they're the only ones doing it. Everybody else is saying, you know, let Jim do it, you know, let Jeff do it,
Yeah.
you know, and you burn them out.
Yeah.
You can't do that. But if you get a large and increasing number of population base, and again, ECMO is one of those classic examples of a labor intense procedure, and you can do that. Suddenly, you're offering a service that is head and shoulders above what we used to do.
Yes. Yeah. It's a different world.
Yeah, that I don't think we realized what big PEs were doing to people as far as heart failure, the follow-up problems with heart failure. Sure,
Absolutely.
you know, you saved a life if you saved a saddle embolus, but did you know, if you did you save a life if you did a thrombectomy on a, you know, on main pulmonary artery? Maybe, uh, uh, maybe not. Maybe they didn't really see the effect of that until 3, 4, 5 years later when they're, you know, a class 4 cardiac.
Yeah. And I'll tell you, when you see, so our guys that do the procedures, they'll take photos of the clot. They'll put it on the blue surgical towel, and then they'll take a photo of it, and then they'll text to you, and it's shocking how much clot is in people's lungs. Shocking.
I know.
We call it clot porn. They send you these photos of the clot porn because it's just so dramatic, the amount of clot. What you see on the CT, oh, I see some clot in there. Then they go do it, and it's massive amount of clot.
It's like seeing one end of an iceberg, and
you see the front end where the blood flow no longer goes. You don't see how long that clot goes down, and next thing you know, you're pulling out a clot that's 4 or 5 inches long, shaped just like a pulmonary artery. It pulls out in one piece. It's bizarre. Yeah.
Yeah. Well, that's great. That's great. Well, I have to say, congratulations to you and to your group and to your interventional group that spearheaded it, that was smart enough to work with the ED, that really worked with Penumbra and all the various equipment that they have available. That you've actually shown probably other areas that are not doing this. I don't know. Do you have a feeling for how widespread this kind of a practice, this capability is?
I think in our city, I don't know much beyond kind of our local city and the region. We're pretty much the only one in our region, which would be, say 75-mile radius, 100-mile radius. So where we are, we're the only people doing it. I think some of the other groups are kind of dipping the toe in the water, which as you alluded to, it's hard to get that off the ground if you're just thinking, yeah, I'll do one if I happen to be on call and it's convenient for me, So I feel like maybe there's been some of that going on. But I do know just from kind of talking to the guys, the registry folks, the kind of support people. I mean, they're starting a national organization, professional society organization, registry. So, and people are jumping on board. So it's certainly growing. It's certainly growing, and it's going to be obviously a game changer for patient outcomes. If we get people on board to put the work in, because it's a lot of work, and there's a lot of clots out there to be evacuated for sure.
Yeah, I remember in medical school saying they taught us that the number of people of postmortems that had PEs was phenomenal. That people did not understand how many people had PEs, and maybe it wasn't the cause of their death, but maybe they died of other cardiac events, and they would go and do an autopsy and realize, gee, this guy had a gazillion PEs. And I think that once we become sensitized, number one, to the fact that a lot more people are having PEs than we realize.
Yes.
Okay, and we need to be looking for it more aggressively. And number two, that, like you say, chances are it's bigger than you think. You see one tiny portion of it, and it actually is much larger than that.
Yes.
And that you now can actually do something pretty aggressive about it.
Yeah. And I think one side that we don't think about until you kind of meet with the team from an ED standpoint is that what's the number of in-hospital pulmonary emboli? You come in for this, right? So like you're saying, you come in because you're sick. Now you've got a clot. So the in-house pulmonary embolism is not necessarily our world, but having a team, having it top of mind, maybe this guy's got a blood clot, and having someone that you're going to call for the hospitalist or the intensivist or whoever that is that's caring for the patient on the floor, having someplace plan for them to do something with the patient, it certainly improves the whole outcome.
Yeah. The final thing that I hesitate to bring up, but it's something that I think if we're the elephant in the room is that with COVID and with COVID vaccination, we have actually seen millions of people, young people even in a hypercoagulable state, more and more people having clots that you would not otherwise think would be having clots. And our sensitivity to clots should be raised, number one. in younger age groups, not just the elderly, fat, sedentary, typical what we used to look for,
Right.
but in younger people who, I mean, I hate to say it, post-vaccination become hypercoagulable, even in the really fit people. I mean, that's some of the research that I've seen that scared the daylights out of me, is that some really fit people have been having PEs and various kinds of clots as a result of their of the metabolism that's changed due to vaccination. So I'm not getting on a soapbox about COVID or about vaccination, other than just simply to say that the world has changed. And there are a lot more cases out there than we used to experience, and they're in different age groups.
Absolutely.
Our,
Absolutely.
our sensitivity to looking for clots should be heightened a great deal, in my opinion.
I agree, especially in a COVID positive patient. You're exactly right. I think you should always be hey, this person's short of breath. They have COVID.
Yeah.
This next question is, do they have a PE on top of it? Right. Yeah.
Exactly.
Is this person more short of breath than they should be? Right.
Exactly.
Why is this person requiring oxygen when their chest x-ray doesn't look that bad and they're COVID positive?
Right.
And then, like you say, young people, fit people, what's their reserve? What's their cardiovascular reserve that they can look decent until or long term, they've got right heart failure, they got pulmonary artery hypertension, long term, they've got disability, right?
Yeah.
If we don't look, if we don't have that heightened awareness for diagnosis, I think it's crucial. It's not a political thing. It's a real life thing that you have to be aware of.
Yeah. You have the number of people that you look for PEs in has gone up tremendously. And you don't wait for the stereotypical situation for it to be in your differential diagnosis.
Correct. Absolutely.
Yeah.
In addition to that, we've diagnosed cancer of people with thrombectomy now, right? This person has a clot. You don't know why. Why does this person have a blood clot? It doesn't make sense. They go and they suck it out and they're like, there's tumor in that clot. You know what I mean?
Yeah.
It's not, they may not be doing tissue diagnosis. I don't know if they're sending that off the path or what they're doing, but just like, yeah, we're diagnosing all kinds of people that with it, now that we're scanning them, we're getting it out. The whole world is, you're seeing new things that you just really hadn't thought about.
Yeah. Yeah. Well, Jeff, thank you for joining me. And I don't know if we covered all the bases that we could. I think this is a lot bigger, as I was saying. I think it's a lot bigger than just your typical thrombectomy of a typical PE patient. I think that we're going to see that more frequently, but now with the right coordination, the right equipment, the right teams, we have the ability to really deeply impact this. So,
absolutely.
Thank you for joining me. I'm thankful for that Penumbra has this equipment that's been developed, our sponsor, and I hope that if you're looking at this this broadcast, that you think that, number one, find out if you're capable, if you're talking about it in your facility. Maybe you're already doing it, but it does merit taking a long, hard look at your capability, who's capable of doing it, expanding that territory, and expanding the ability, the service opportunity that you have for your patients. So thank you for joining EP Talk, and for Penumbra for supporting this broadcast. Thank you very much.